And panel, thank you. Very, very thoughtful comments in the last 25 or so minutes. I'd like to focus a little bit more. I have a few questions for you, and then from the group, get ready to queue up with your questions. Renu, I want to start with you. There's a lot of commentary from the entire panel about data. So what is it that we need to do? What new data do we need, or what data do we have that needs to be explored in particular ways that could be fruitful in this?
So I am firmly convinced that if we want to improve our healthcare system, we need a network across the country that combines claims data, clinical data, social determinant information, minimally census tract information, which gives you a good measure of community deprivation, and perhaps if you get to a 9-digit zip code, a little bit more information about socioeconomic status, but ideally robust social determinant data like is being collected by several pilot projects right now, and biospecimen information. I mentioned the clinical data research networks. There's 13 of these across the country right now. Across these 13 clinical data research networks, we now have about 110 million patients with clinical data that is standardized and in a uniform element so that information can be shared and compared. About a quarter of that is linked to claims information, and maybe a tenth of it overall is linked with some type of social determinant information. We, along with 2 other CDRNs, one in Florida and one in Chicago, have started to ask questions of these combined data sets about what we call modifiable. Instead of impactable, we're using the word modifiable because it's a word. Although the dictionary never, my autocorrect doesn't recognize it always. Modifiable high utilizers. And so it's interesting because as I was reading this report, I was comparing and contrasting this taxonomy with the taxonomy that we have started to develop. So what we did is we looked at 4 million patients in Florida and New York. We had combined claims and social determinant information, and what we strove to do was first develop computable phenotypes, meaning categories of patients that could be that we could write specs for and query the data set for. We didn't create mutually exclusive categories, so we allowed patients to fall into more than one category. And we did incorporate behavioral and social issues because we could. We had the data sources that allowed us to do that. We ended up with 6 computable phenotypes, some of which you see here in this report, a couple that were new. And then we went and we pressure tested it. We convened several focus groups. We ended up with 100 patients, health system executives, and clinicians, and we said, what has face validity and what doesn't, and what do you think is impactable and what do you think isn't? And it was fascinating. One of the categories was demoted because everyone felt uncomfortable about it, and they introduced 4 new categories, including, interestingly, one on the worried well. And as I was reading this report, the very first taxonomy developed in the 70s included the worried well. And we're having a hard time operationalizing that one. But what was really fascinating to me was that the amount of overlap and intersection between our work, which took a different philosophical bend, and this work was very, very significant. And I think it really gets to the fact that we need to have the data on social issues. We need to have data that allows us to understand behavioral issues. Functional issues, I think, is really, really critical. And then the more we can get to, I think, race, ethnicity, and the impact of that on expression of disease, the better off we'll be.
Thank you. And from the standpoint, there's data that comes from sources I think you said in your initial comments and the conversations that we've had, best source of data are the patients themselves. And so I'm curious about your thinking on the best way to integrate patients into care delivery redesign.
No, thank you so much for that question. So, if you're interested in creating patient-centered care, you simply can't do that without patients. And I find it helpful to think about embedding that engagement at 3 different levels. One is at the clinical setting, the second is at the level of the practice or healthcare organization, and the third is in policymaking. And there are interventions that are needed at all 3 of those levels. So at the clinical setting, there are tools to improve engagement. I do want to put in a plug, since we're here at NAM, for a report, an NAM paper that came out earlier this year, which was devoted to how to harness evidence and experience to create a patient-centered culture. Since we're talking about our favorite papers, one of mine is a family medicine paper from 2001, which tracked the content of a typical patient visit. Patients spent 31 minutes waiting, and they had 11 minutes with the provider, during which they spoke for 4 minutes. So how can we engage patients if we give them only 4 minutes of our time? So this is one of the systemic barriers to engagement that we need to address. At the organizational policy levels, we certainly have worked in our center to support and train consumers who are participating on advisory committees, who are working to improve practice. And so that work is generously funded by the John A. Harper Foundation and also the Robert Wood Johnson Foundation. I'm excited that over the past, say, 12 to 18 months, we've seen a lot of new literature come out about what works in this type of engagement and in identifying the areas such as recruiting patients from underrepresented communities that we need to continue to focus on. And we need to keep a clear focus on addressing disparities in engagement. Some patients are already activated, but how do you reach the ones who are not? And also we need to acknowledge the historical and the current injustices and discrimination that make it more difficult for some people to engage and get the care that they need. Joanne, I wanted to thank you for your comments about community, and one of the best titled papers I saw recently was Bowling Alone, Dying Together. And it looked at the correlation between what are referred to as civic deserts, areas where we've lost community and civic engagement in organizations, and deaths from the opioid epidemic. And I think we need to think about how do we regrow and restructure, going beyond the confines of the current system, but how do we regrow that kind of engagement and the strong communities that we need to ultimately address this problem. So the short answer is, when I think about engagement of patients in these models, in the same way that we think about providing technical assistance to healthcare providers to help them adopt new models of care, I think we need to be just as thoughtful in terms of outreach and training for consumers as we ask them to participate in these new models of care. So at the center, we are working to build some of that consumer network and the tools and resources that we need to foster that engagement, but we certainly can't do it alone. And I think that's an area where we would certainly welcome collaboration on that front.
Thank you. Dave, you're right there at the point of service, yourself personally and the team. You made mention in your opening comments about matching the taxonomy to the models. You would take a little deeper dive there in terms of how you might use this report?
Yeah, thanks for that question. I think it arcs back to something that Peter said in his opening presentation, which is, do we have enough in this report, in the taxonomy, in the way that we think about risk to start going and doing. And that's really sort of where we are within our own system at Health and Hospitals, kind of a microcosm of the broader problem. So I want to try to be as concrete as possible. So I'll share with you what we did over the course of the spring in our system, which was to actually catalog all of the different care management programs that exist across Health and Hospitals. We found that there were 35 programs, from collaborative care for depression, based on the impact model, to Health Home, to a CMMI-funded ED care management program. And so, as has been expressed before, unfortunately, our highest need patients, they experience the fragmentation of our healthcare system most acutely. And so where we've tried to take that is to say, okay, we have these 35 different care management programs that care for a few hundred patients here, a few thousand patients there. How does that actually map onto our assessment of who our highest need patients are? So let's just start at that very high level. So I mentioned, we're looking at our top 1% high-risk patients, which for our system is about 12,000 people, a group that we can, wrap our arms around, and figure out how many of those 12,000 patients are actually in one of those 35 care management programs. The answer, probably not surprising to many of you, is that the majority of those high-need patients are not in one of those 35 care management programs. So at the same time, we have this panoply, of initiatives, and they're not meeting the needs of our highest need individuals. So, I think where this is a little bit forward-looking, again, both for us as a system as well as the field, I think the things that we have to tackle, we'll just put two on the table to try to address that gap. One is building on what Jeff said, which is how do we actually outreach and engage, those patients, what I think of as the patients we do not see. We have this expression in medicine of seeing patients when we round in the hospital or when we see patients in the clinic. What about those patients that we do not see, and how do we actually get them engaged in care, and particularly for our system where we see many undocumented immigrants, patients who are transient because they are homeless or have unstable employment situations, for various reasons. How do we meet their needs in a way that feels salient and and actually gets them engaged in more longitudinal care? So I think that's one major area that we're thinking about. And then the second also has been alluded to and is mentioned in the report frequently, which is how do we take advantage of the latent natural resource that caregivers represent? And that's something that I can say, our system does not do in a systematic, comprehensive way, to think about how it's not all about, pouring more resources and having a higher touch intervention from the health system's perspective, but it's about enabling those natural support systems that often do exist in communities that we're just not supporting well enough.
Thank you, Dave. Jeff, you and I had, at least for me, it was a fascinating conversation at lunch, and I think I mentioned that I had a well-informed health policy person say to me, well, it's fine to identify these models, but they just don't scale. PACE has been around for 35 years or longer, doesn't scale. There's only 30 of them across the nation. You had a reaction to that. And so I'd like to know your perspective on what's the infrastructure necessary, what's it going to take to accelerate spread of these elements that the panel has identified and the report's identified.
So I want to use a little learning by analogy around safer cars, cheaper and safer cars. So, just sort of think a little bit about the history here. In 1966, the Smith Foundation funded a TA program to pull auto engineers and drivers and executives together on building safer cars. Then the Jones Foundation in 1972 had a grant program aligning forces for better cars. Then in 1976, the Roberts Foundations had studied positive deviance, found the one car and the one driver that didn't explode and were cheaper. Then in 1981, there was a landmark report, the National Academy of Engineering report on building cheaper and safer cars. In 1987, the Department of Transportation had a grant program on building safer and cheaper cars. In 1995, GM finally built a safer and cheaper car, a pilot car, but then they took it back off the market. Then, finally, they started releasing voluntary data. In 2006, we did begin to have seatbelts, and in 2018, next year, I think we're going to have voluntary airbags. So, my point being that in our industry, for some reason, we're holding the healthcare industry to a much lower standard than we've held other industries, right? I mean, we're injuring people every day by how bad our delivery models are. We spend twice as much as other countries, and we use really soft tools, right? Like, let's take kid gloves, like these highly educated physicians who've had years of education or in the top 1% of income are delivering an inferior, disorganized product. Hospitals that are garnering enormous amounts of resources. And this is not to make light of, Foundation's grants and reports like this, but really just that we, from a scaling point of view, we've been relying on some fairly weak tools at times. So, so ideas scale, culture scales, value scale, model scale, but laws scale, right? I mean, so the reason we've got safer cars is we had, an outcry from the public, and then we had changed laws. And looking at the models that have scaled, there are folks that have grabbed the levers of power. So, I've had Jenny Chen Henson, I've had a wonderful time talking with her about the history of PACE, and they got the ear of someone on the, I think the Commerce Committee, one of the staffers who literally said, let's just write legislation. And suddenly PACE is, they could have toiled in obscurity for 40 years as a grant-funded project, hanging on by their fingernails and not gone out of business, or they got legislation passed. There are other models that have just grabbed the legislative lever. So I think what it partly argues is one of the issues is I think foundations, some foundations have been afraid to use legal tools to draft model legislation. There's no violation of the 501c3 structures of foundation structure to begin to draft model regulations and model laws. There are conservative foundations that have done this, but by and large, we've been afraid, I think, of the legal sphere. So one way to scale is to use the legal and regulatory environment. We've scaled a lot of things. We've scaled courthouses, democracy, public schools, hospitals, universities, bridges, buildings, roads, iPhones, autos, open heart surgery, and arthroscopy. We do 650,000 arthroscopies, of which 80% are unnecessary. So we're totally capable of scaling stuff. So in my heart of hearts, I believe we probably could scale stuff that's working. The nurse-family partnership has the most robust 30 years of randomized controlled evidence showing kids and adults are better off 30 years later. We've got an ROI on it. I don't know how much more evidence poor David Olds could collect, but still we haven't scaled it across every kid who could benefit from it. Then we've got really interesting projects like Ken Coburn's model in Doylestown, where they actually have randomized controlled evidence for 1,700 patients where they lowered the death rate. Anyone ever going to do that in your lifetime, right? And not by a little bit, but by 24% across their population. That's more dramatic than all of the treatments that I have in medicine. And it's just from a highly qualified nurse going out. And they were part of a Medicare chronic care demo where CMS pulled the plug on them and Aetna just pulled the plug on them. So, they're going to fade away in security. Someone 20 years from now will discover the article in the literature and say, now how did they do that? So, it seems like we have a lot of failures in our ecosystem for scaling in this work. And we don't have clear language for it. We don't have clear thresholds of what evidence gets you to, what level of funding. We don't have clear sort of policy framework to do this. So we have a lot of work to do to straighten out the scaling and the knowledge building ecosystem in this work.
Thanks, Jeff. So, Steve, you get the last question before we open it up to the panel. I think Jeff just set you up beautifully.
I think my last comment, I can rest assured that Jeff will continue to yell at me.
So I think the question is and with your wealth of experience, what do you think the policy incentive payment initiatives need to be in order to move this forward?
Sure. And I would just echo one of the comments that I think, Peter, you made, which is that, we are at an inflection point and we should move to implement now. That is where we are. And I think CMI in particular agrees with that. So how do we think about what we can do to actually get past this inflection point. I think there are sort of three buckets of work that we've been thinking about. One is thinking about the enabling steps. So whether it's data, whether it's quality metrics, whether it's the SIM type work to help our states get the infrastructure to think about how to tackle reform like this, everything from the data and quality analytics to just setting up and implementing practice transformation for providers. So there's those types of SIM type efforts. I would mention that the Medicaid Innovation Accelerator Program, which is a partnership with the Innovation Center, with the Medicaid Center, CMCS, is a project that really focuses on the idea that there are lessons that we have to uncover within the Medicaid space, and so partnering to develop some of those. One of those main initiatives focused on, as we call it, beneficiaries with complex needs. If you just Google IAP and CMS, you should get to their website. But I would point in particular to the beneficiaries with complex needs. There were 4 webinars that we did with various staff. The titles of them may sound familiar. There was Identifying Beneficiaries with Complex Needs. It was Effective Care Interventions. It was Payment Policy around beneficiaries with complex needs. And the last one was around some of the data issues. So I think, again, that synergy, that sort of that idea that we're all at this point seeing this in a similar way, I think, and your work to really elevate that to say this is where we are is just fantastic. So I think first the enabling steps. How do we help payment strategies be more effective, whether that be through data quality or just infrastructure within the states? I think there are specific initiatives that are looking for proof of principle. So we just announced the launch of the Medicare, Medicaid accountable care organizations, and so that was earlier this year. We're looking for states to participate. So we're on a search for trying to think about how a duals and an ACO format might work. We are working with Comprehensive Primary Care Initiative, which many of you know about. It's our sort of premier primary care intervention, both CPC Classic and CPC Plus, as we call it. We also have the accountable health communities, which is really thinking about how do you screen for health-related social needs and connect beneficiaries with interventions for those. So you see all these elements, and of course the ACO projects in general, which are really trying to think about a payment strategy towards health systems to encompass all this. And I would say if you're a good ACO and you're not thinking about this, you're not going to be doing very well. I think all of those are a myriad of specific initiatives, both marrying up Medicare and Medicaid. I think you talked about some of those in yours. The integration of medical, behavioral health, and social services. You were seeing those particularly in AHC. And by the way, a lot of our Medicaid managed care plans doing some fantastic work in terms of thinking about how do you do this under that umbrella of capitation. It is in our interest as a Medicaid managed care plan to think about this. I think about Care Oregon and some of the work they've done. I think we trot out the similar examples all the time, but some folks have done some fantastic work here. So I think we have a few initiatives that are really thinking about how do we pull and tease apart one of those at a time. I think part of the reason that I moved from Medicaid to the State Innovation Group was the last opportunity, which is this idea, and I think, Joanne, you picked up on this in your comments, which is go big, go all in, go in a region. And so this idea of a multi-payer statewide transformation that we began this journey with Maryland with global budgets for hospitals. We expanded from that work to Vermont to thinking about an ACO across the entire state, paired with an enhanced primary care intervention, paired with a community-based intensive needs intervention and a specific intervention around SUD beneficiaries, and really thinking about scaling those initial primary care and community health teams to a more statewide approach and trying to see what that looks like. We're in the midst of trying to launch that right now with Vermont. But I think when I look at, and again, I commented it already, when I look at your taxonomy of service delivery options, I guess, what I don't see yet, and I think we are trying to do, is all of these together, right? So when I think about an accountable health community without an enhanced primary care medical home, they're going to have trouble. When conversely, and again, I think most of us here are clinicians here, when I see patients in a homeless setting, when I'm in a homeless setting and I don't have, as I don't in DC, an accountable health community to refer to, that's a challenge for me too. So this is where our ideas of Vermont, hopefully the future of Maryland, we're talking to them right now, is really pulling all of those threads together. And I think some of the limited evidence we've had to date, primary care, maybe it breaks even, maybe we save a little bit of money, AHC, we're not sure yet, the accountable health communities, but we're thinking that if you put all those together and maximize the interaction between those two and pull in the hospital accountability, whether through an ACO structure or however, pulling all those together under a financial umbrella, what you're doing and what CMS want, and I, from the State Innovation Group perspective, I'll speak for myself, I want us to do what we do well and not do what we don't do well. So let me be more specific. Dave and Ann and Jeff, when you talk about some of the specific clinical interventions and some of the intricate decisions that you make on a daily basis, or me in my clinical practice, you don't want CMS making those decisions for you, right? So what I hope we can do is go a more global setting, and this is where the health outcomes come in. If we can think about part of our payment attached to population-wide outcomes, not just an attribution-based formula, but in a geographic model, population-based outcomes, we're just starting that. We're sort of putting our toe in the water here to see how this goes. I think, again, this goes back to my earlier comments where the population health strategies are the beneficiaries with complex needs strategies and vice versa. If we can get to that point, get CMS out of the mix and empower the local entities to be more successful in choosing those specific modalities, whether it be finding the folks who are going to be next year's high utilizers who haven't come to the doctors, whatever that is. I don't know that sitting here in Baltimore, and I don't want to know that. I want to let providers have the incentives and authorities that they need to get that job done. We have more work to do and more regs to unpack and more barriers to break down. But I think in a nutshell, at least from the innovation strategy, it's paying more globally to let folks have more flexibility.
Thank you, Steve. Time for a couple of questions, Michael, or would you like us to? Go ahead. Yeah, questions?
I'm sorry, but if no one else has a question, I don't want to waste this time. For Stephen, I think population health is precisely the wrong approach. And it's very frustrating. You can hear it in my voice. Most people are healthy most of the time. The medical system is for sick people. That's what we learn about in medical school. That's where a lot of research has been done. That's where we can make a difference. It's not about diet and exercise. That is a public health problem. There's not much doctors and their patients can do about overweight if you have a zillion-dollar industry promoting sugary products. It's just that simple. If you would talk to us at the front lines about what we need more time with complicated patients, and we should get paid more for complicated patients. And that's an easy thing to do. You can do it at CMS through the RBRVS system. They already do it in Medicare Advantage. Pay doctors more for complicated patients, somebody who has 10 chronic problems. Give us enough time to talk to them and then give us access to a social worker.
So your question is, Steve, is that something that's possible?
Why don't we think about it that way?
So I think two answers to that. Number one, I think that's the core of most of our primary care, patient-centered medical home approaches, whether it's CPC or whether the embedded enhanced primary care approaches.
No, that's for healthy patients.
Well, I think, again, the point of some of those enhanced primary care is to allow the clinicians to understand who to deploy those social workers and the caseworkers to employ more team-based approaches. 30% of the reimbursement has been moved to a practice-wide payment, not attached to any individual, to allow the practices the flexibility and the clinical judgment to say, I need to spend more time with this patient, I don't need to spend more time with that patient. That 30% of all of our primary care reimbursements allows those docs the flexibility to think about that. In addition, that's on top of the bump up that we're paying the primary care docs. The second point on whether we can do something about diet and exercise, I would just disagree. I think we can look at the history of diabetes prevention program and multiple interventions where we have successfully deployed community health workers, partnership with community-based organizations to see a change in the arc, and unless we're actually thinking about those underlying social determinants of health, everything we do is going to be icing on the cake, and we're not going to be able to solve the patient's problems.
So we've got another question. Thank you.
I really like the idea, this is Joanne Lynn, I really like the idea of global payment. I mean, I have this idea that we need to change how the medical care system is paid every decade or so, because it takes us that long to learn to abuse whatever it is that came up. But in the short run, it is astonishing how much you can do with a relatively small percent of the medical care side of the equation. I mean, there are 800 people awaiting Meals on Wheels in Detroit. It would only take a few hundred missed hospitalizations to pay for all of them. $7 a day for 3 meals. So, I think that we could go for global payments. We can hold our breath to see if Congress could ever allow us to do anything. But if just the savings, if a chunk of the savings could come back to the system as flexible money and be allowed to be used in meeting these social issues and the personal care issues, it's really enough to provide tremendous leverage. So we don't have to go all the way to salaried systems or global payments at the first cut. We could do it on the savings alone.
One more question, then we'll turn it over to Michael.
Hi, I think this is just really tremendous to hear this versus all the other things that are going on in the country right now about healthcare. But one of the things I'm not hearing so much is I still feel like for especially these high-need patients, we have a culture of no. And this is something that patients struggle with their families, which is going to the pharmacy. No, you can't get that prescription. Calling the doctor's office. No, we don't have an appointment for you, et cetera, et cetera. And I feel like that also needs to be incorporated into this initiative, and I'm just curious what you have to say about that, because I think patients and their families want to participate and want to take the initiative in their own health care, but this is a real struggle for them.
Well, Jeff, you talked about underutilizers, and Ann, you talked about engagement. Would you like to respond to the point?
We're actually spending a lot of money. I think that was the point you were making, and not enough on sick people. So, if you just look at how insurance actuaries set payment rates to practices for cap rates, if you look at the RVRVS system, just that there's a maldistribution of where the money's flowing. No healthy person really should ever see a doctor. There's no evidence base for a checkup. So, in fact, we're more likely to harm you if we do a checkup. We're more likely to find stuff that doesn't need treatment and then treat you too much. So probably no healthy person should ever see a doctor. People with chronic illnesses, we're frankly not very good at treating you either. Like, you look at the evidence base for blood pressure, the meds we choose, the algorithms we follow, we're not very good at chronic illness. Nurses are much better at that, and you would have a whole protocolized model. Then you'd get to really, really sick people, and we're so underpaid for them that we ignore them. So there's like just a tremendous mismatch. The irony in the RVRVU system, which is the calibration system for how we rate set, is that inside of ACOs, the ACO has got a global payment structure, but if you actually look at how the doctors are being individually paid in their salaries, they're all based on the Medicare fee schedule, which is the Medicare RVRVU system. So, the irony is that we're still using RVUs inside of systems that have now moved to global payment. And so the bias that's being built in from the RUC, moving into the RVU, moving into the fee-for-service system, still is the basis for so much of what's going on. So I don't know the answer to your question. It's going to take a long time to fix it.
It's always hard to follow Jeff, but I'll just say that I agree that the healthcare system, for those who unfortunately do need to seek care in the system, can be incredibly frustrating and challenging. And it does feel like all of the work is put on the patient or the family, the caregiver, to navigate this incredibly fraught system. If you've ever tried to get medical records, transferred from one facility to another facility, it feels like this gargantuan task. And if you multiply it by, 20 specialists and multiple hospitalizations and procedures and meds, you can literally spend all day trying to do a simple thing. So I think that piece around a culture where the patient's needs are put first is a really important piece of the transformation, and I agree that that needs to be a very strong area of focus.
Would you help me thank the panel? Nice job, panel. Michael?